Hi, my name is Clara, and I will be an upcoming junior at Shaker Heights High School in the fall. And I was in the medical laboratory internship program this summer. My project is the inter-platform validation of HER2 testing in gastric and gastroesophageal adenocarcinoma. Gastric cancer is the second most common cause of cancer-related deaths in the whole world, with the 5-year survival rate for advanced metastatic gastric cancer being only 5 to 20%, while the median overall survival is only 1 year. Recently, there's been a lot of studies evaluating the connection between the human epidermal growth factor receptor 2, HER2, and gastric and gastroesophageal adenocarcinoma. This protein is a member of a family of receptors that has been shown to drive apoptosis, cell differentiation, adhesion, and migration. The HER2 gene is shown to be overexpressed in about 7 to 34% of all gastric cancers, and in some instances, overexpression has been related to the worst prognosis. HER2 overexpression is identified by two processes mainly: immunohistochemistry and in situ hybridization. And this leads to a target for the humanized monoclonal antibody, trastuzumab, otherwise known as Herceptin. This picture on this slide is an example of the fluorescence in situ hybridization method. And you can see the green dot represents the centromere of chromosome 17, where the red dot represents the HER2 gene, actually. So you can see that the gene is very expressed in this case. There are many different ways to determine HER2 status and amplification and overexpression, and this includes what I just talked about, IHC and in situ hybridization. For IHC, the two different types that we used in my study were Ventana pathway and Dako-Hercept test. For in situ hybridization, we use FISH and DISH, also known as PathVision or Ventana Inform, which is the dual in situ hybridization method. HER2 testing actually began in breast cancer, and it's still going on now. However, now it's moving more towards the gastric cancer areas to figure out the same, to learn about the same materials that happens in breast cancer as also reflected in gastric cancer. However, since breast cancer research for HER2 testing has been going on for a while, there are established guidelines produced by the American Society of Clinical Oncology, as well as the College of American Pathologists, that help guide testing parameters. However, there are no official guidelines for gastric cancer yet. This slide shows two pictures of dual in situ hybridization methods. On the left is non-amplified one, and you can tell because the red dots represent the centromeres, that's chromosome 17. However, on the right, it shows an amplified version of tumor cell because the black dots represent the HER2 gene copies, and the black dots are very prevalent there and greatly outnumber the number of chromosome 17 centromeres. So the trial that my study was based off was called the TOGA trial, also known as the trastuzumab for gastric cancer trial. And this was an international trial that included about 8,000 patients worldwide. And this was in order to test clinical efficiency and safety for clinical use. Trastuzumab was what was being tested, and is also known as Herceptin, and this has improved the length and overall survival in HER2-positive patients by about 2.7 months, which is really a lot considering the average survival is only 1 year for gastric cancer patients. In this trial, 22% of the patients qualified for Herceptin treatment, and this was decided through positive IHC and FISH results. So how does this all connect? Well, trastuzumab treatment is determined for eligibility through HER2 overexpression and amplification. And how Herceptin works is the following. The epidermal growth factor, as you can see on the picture, should bind as a ligand to the HER2 receptor, and this will establish a signaling pathway that expresses the HER2 gene and leads to amplification in the future. However, with Herceptin, it binds to the HER2 receptor and therefore blocks the binding of the epidermal growth factor to the receptor and also blocks the signaling pathway. The Dako staining process was what was used in the TOGA trial, and this included IHC and FISH. More specifically, it included the Hercept test and PharmDX. IHC is a target antibody antigen binding that has color reaction, and it really focuses on the proteins that are found on the cell. In fish, they use probes to target the DNA sequences, and it highlights the HER2 ratio expression to chromosome 17. Now, Ventana pathway IHC is a different brand, and this has been internally validated in Cleveland Clinic to reference in situ hybridization standard with greater than 95% concordance, which is really excellent. The objective of my study is to cross-validate the Ventana pathway IHC with a DACO-HERCIP test IHC in order to ensure accurate HER2 results for clinical use. First, I sorted through all the patient information, which had already been tested using Ventana pathway and Ventana Inform. These qualified patients, it was about 21 cases, and they were chosen based off of concordance between the pathway and Inform results. Next, we took those 21 cases and we ran the tissue through the DACO-HERCIP test. Then we scored them based off of the criteria that was used in the TOGA trial. We compared the DACO scoring results with the previously stained Ventana results, and we used chi-squared analysis between the two IHC methods to determine concordance. So of the 21 patients that were included in my study, they were all gastric or gastroesophageal cancer cases. However, excluded from the scoring methods were those who had intestinal metaplasia, regenerative changes, basal staining, luminal staining only, cytoplasmic staining, edge artifacts, or crushed artifacts. Here's an example of the criteria that we used in order to determine the protein expression in biopsies. We scored both biopsies and resections, and I wanted to point out the difference between the biopsy and resection results. In biopsies, you only need 5 cells in order to be called a tumor cell cluster in order to call it negative or positive in terms of cancer. However, in resections, you need more than 10%, which is significantly greater, because resections do cover a greater area of tissue. Here are some pictures that we took during our study representing the different cases. In figure 1, this is considered negative because there really is no staining and it's very, very weak, if any. In figure 2, the stain had not much reactivity, but there is a little staining. You can still see it, so it's considered 1+, not just 0, because it shows faint and partial membranous reactivity. In figure 3, the equivocal is 2+, and you can tell it's a 3 because it's a 2+ because you can see the staining very clearly. However, it's still weak and moderate in terms of membranous reactivity. In figure 4, this is definitely a positive staining result because it's very strong, complete membranous staining. This is a chart of all 21 patients that were included in my study. What I wanted to point out, what we noticed exactly, was only one of the cases displayed different results between DACO and Ventana IHC classes, with DACO calling DAG 107 positive and Ventana calling it equivocal. Also, in the same case, DAG 107, we scored both the resection and the biopsy, and we found that the biopsy and resection differed even with the exact same staining process, with resection being positive and biopsy being negative. And this is a huge concern that should be brought up in the future for recommendation. We also noticed that there were 6 equivocal cases that were identified through DACO and Ventana. And of the 6, we had to use the DISH HER2 chromosome 17 ratio to determine amplification status. So we found of the 6 that 3 were considered amplified and 3 were considered non-amplified. Our results basically showed that 20 of the 21 cases showed agreement between the 2 IHC testing platforms, which is really excellent because it's greater than 95% concordance. We also used chi-squared analysis to determine the p-values for DACO and Ventana testing. And the Ventana pathway, which we actually used in the Cleveland Clinic, was actually the p-value was a little bit better, so that's really good. In conclusion, the excellent concordance between Ventana and DACO testing displays that it is very efficient and safe to use Ventana in Cleveland Clinic, especially in clinical settings. However, we do have to note the heterogeneity of the HER2 expression between biopsy and resection scoring. For recommendations, I would suggest further study in the biopsy and resection heterogeneity because that's really an issue. And one way to prove that, one way to test that is when testing biopsy results. If it comes up negative, it's really important to test it again for resection in order to get a more accurate result. You should also test the in situ hybridization methods because in this study we only put into use the immunohistochemistry methods. So we should be able to inter-platform validate the DACO fish farm DX with their in situ hybridization method. Lastly, this algorithm was used in the TOGA trial, and based on our results, it was actually verified by this study, and we determined it would lead to very accurate results, especially with the eligibility of Herceptin use. I would like to give a special thanks to the Office of Civic Education Initiatives, especially Ms. Starling, Mrs. Strickland. I'd also like to thank my mentors, Dr. Downs Kelly, Mindy Krall, and Brad Skilton. I'd also like to thank the Anatomic Pathology Department as a whole, and most importantly, the Surgical Pathology Laboratory that I worked in this summer. Thank you.